Hello, everyone. Thank you so much for joining our Wellness Wednesday webinar. This is a platform where we have special guests and speakers talk to you about physical and mental health and well-being. Today, I'm excited to be on this journey with you and welcoming Dr. Aneez Ahmed from Singapore. Please remember that you are able to submit your questions through the chat feature on this platform, and we will get to them in the second half of the session. A little bit about Dr. Aneez Ahmed. Dr. Aneez is the first in the ASEAN cohort to get a level 3 certificate in robotic thoracic surgery. He is also the only accredited surgeon in Singapore trained to perform robotic thoracic surgery and the only proctor for thoracic surgeons in ASEAN. Joining us from Singapore today to give us smart advice against the battle of lung cancer. Dr. Aneez Ahmed, thank you so much for being with us today. How are you doing?
Good evening. Thank you for having me, and assalamu alaikum to everybody in the UAE listening.
Well, welcome on the platform, Dr. Aneez. We're so excited to have you with us today. It is Lung Cancer Awareness Month, and it's such a timely opportunity to have this discussion together. So could you tell us a little bit about yourself, your profession, how you specialized in this field?
I live in Singapore. I trained in Singapore. I started training in the field of cardiothoracic surgery. I'm a heart and lung surgeon, but I moved on to pure thoracic surgery, which is management of diseases in the chest, except the heart, for the last 15 years, because my specialty interest has been in lung cancer and other cancers in the chest. Cancer has always been a fascination, and we take it as a personal fight to one day get rid of cancer in this world. As far as the interest in robotic surgery goes, I am a son of an engineer, and my family is full of engineers. So I took up medicine. I have been interested in robotic applications in the medical field since 1998. And I had the privilege of working with the first robot, which took down memories in the chest, which used to be a robot called ESOP. And since then, we've had nearly various versions of the robot, and this is the best vehicle. You could say we've progressed from a manual car to a Ferrari right now, and we are capable of operating this machine to help our patients with lung cancer.
Thank you so much. That sounds very exciting and inspiring. Before we get started and jump straight into that, could you tell us what are the symptoms of lung cancer and a little bit about it for those who are watching and may not have a very clear idea?
Okay. There are a lot of things which can be related to symptoms of lung cancer. So the first one, the most common one, unfortunately in a flu season where we sit right now, is cough. And it is a cough which will not go away. So that is the first danger sign. Second sign is when the cough gets related to either spitting out blood or feelings of what you would see as uneasiness whenever you cough, and it's being related to the chest pain along with the cough. So any cough related with the chest pain which comes with it is another symptom. The third one is general feeling of malaise and weakness is also a very common symptom associated with lung cancer, because it is a cancer which eats away from inside, it drains you, it takes away a lot of energy, so people generally feel lousy. The other things can manifest as part of a local manifestation, things like pain in the back or pain somewhere else, which are usually dangerous signs, including pain in the head. These are dangerous signs. This means the lung cancer has spread to these organs. And it's probably at a much later stage you get all this. And lastly, you can also land up with shortness of breath, which is also a very common symptom which can be related to anything. If you ask me to suddenly climb 5 flights of stairs, I will be short of breath too. But that is different from a patient with lung cancer having shortness of breath. This shortness of breath should happen when you're at rest, and it is related to the disease, and that's how it comes about. These are the common symptoms, but the most important thing, I reserved it for last. You want to pick up a lung cancer when you're asymptomatic. That is the key thing. That is why most of the patients who are diagnosed with early stage lung cancer are asymptomatic. They would have gone without any symptoms for something else to the doctor, and they would have gotten this picked up. So always remember, there's a condition called asymptomatic, which is very important in early stage lung cancer.
So that's very helpful, Dr. Aneez. So at times you can be asymptomatic and not see any, glaring symptoms, and then there are times where the symptoms may seem very common or not so serious. So it must be a challenge to be able to detect this kind of cancer. What are the screenings or tests that are recommended to know at an early and detect at an early stage?
Good question. So because lung cancer has this problem, unique problem, where we are not able to diagnose, that is why it is the leading cancer killer in the world. For both the sexes, for both male and female, lung cancer is the leading cause of cancer death in the world today in all countries, male and female. The problem with lung cancer today is not much different what it was 60 years ago. We still handle about 80% of the lung cancers in stages 3 and above. Most of the early stage lung cancers are missed. So if you look at my number, we are still looking at 15 to 20% of early lung cancers. And those are very curable. In the Asian population, this has changed because countries like Japan and Korea have very strong countrywide screening programs which make them diagnose their lung cancers early and give them a very high cure rate. The key word is cure rate. So how can you screen for lung cancer? There are no set targets, but there are some very valid papers and guidelines which have been issued by different societies. The most commonly quoted one is the one which came out of the US, which is called the National Lung Screening Trial. So basically, this includes all people who are smokers and also who are ex-smokers, who are like smoked for any number of years and have quit. People, these are the most common category, the smokers and the ex-smokers. The second category will come like this, the people who have history of cancer. They could have had a history of other cancer. So once you have one kind of cancer, you will always at risk for developing a second cancer. So those people should be screened early for lung cancer. The other thing is family history of other cancers. You could have had people like different cancer, colon cancer, or other cancers in the family. I'm not saying that your cancer risk is high, but you are in the category where you should be screened early because you have a propensity, relative risk is higher in you. The third is based on occupational category. People who work in shipbuilding, spray painting, anything to do with petrochem, you're in that part of the world, in Dubai and the surrounding regions, petrochem is a high risk for lung cancer. It is more higher risk than pollution. You should remember that. Things like working in a semiconductor environment, all which has aromatic benzenes in their work area, all these increase risk of lung cancer. So they should be part of an annual screening program, we feel. And also, people who have worked in asbestos industries and who are working in asbestos industries, they may not be directly only related to lung cancer, the risk is high, but they are also related to another condition called mesothelioma, which is a very bad disease of the chest as well. The last category is what I want to talk about, where the screening becomes a little bit of a skewed curveball. This relates mostly to Asia. We have recently found that more and more Asian women who are non-smokers are starting to get lung cancer at a much early age. The reason for this is unknown. but there have been definitive studies which show that there are new types of genetic mutation which are the cause of these lung cancer. So when do you screen these women? The answer is not there yet. But if you feel uncomfortable, or if you kind of there with any symptoms which you feel, or you're part of a general screening program, ask them to include a screening schedule for lung. How do you screen for lung cancer is the next question. The most common modality is CT scan. It is not your regular CT scan where you need an injection and a high dose. You don't need. A screening for lung cancer can be done using a low dose CT scan and without any injection of contrast. It is called low dose non-contrast screening scan. You even have ultra low dose CT scans, which is equivalent to just about 9 chest x-rays, which is very good because the older CT scans used to be like 35 chest x-rays. So now the latest ones, which is called the ultra low dose CT scans, is equal to anywhere between 7 to 9 chest x-rays, which is definitely worth in somebody who's in a higher risk category because diagnosing lung cancer early will save his life. This is the bread and butter investigation for lung cancer. There are other newer things. So we have a blood test, which is in a very new technology development, which basically recognizes antibodies from the lung cancer in your blood circulation. You require about 3 mL of your blood. So and if you combine this blood test with the CT scan, the chances of you diagnosing cancer is much higher. So this point in time, these are the 2 most valid tools for diagnosing lung cancer.
That's great. Thank you so much. I think that really sheds light on all the other factors that can contribute. The typical message that you see is, smoking is directly correlated, but perhaps there's a lot more factors at play that could be, unrelated, or, as you said, ex-smoker. That's very helpful, I think, for our viewers today. So taking that information, can you explain to us in that context, where does the robotic thoracic surgery fit in? What does that mean? It sounds so futuristic, but how do we understand that, in our non-medical day-to-day lives? What does that look like?
Okay, so first of all, let's clear ourselves. Robotic surgery means the robot doesn't do surgery. I do the surgery.
Okay.
Okay, the robot helps me do the surgery. Okay, that is the most important thing. In the present surgical world, we operate using instruments looking at a screen, which is called 2D vision surgery, which is called video-assisted surgery. In the robotic surgical platform, it becomes 3D vision. So you can actually look into the patient's body and see how it looks. May I share my screen with you?
Absolutely.
Just how it looks like.
Mm-hmm.
Give me a second. Okay, so these are the 3 parts of the robot. If you can see my cursor on the screen, this is called the boom. This is the robotic arms. As you can see, there are 4 arms. So God gave me 2 arms. Now I've grown 2 more. Okay, so that helps for a start. I have more arms. So this is called the console. This is where we sit and operate. And these are the robotic arms. I can move my arm and wrist to up to 180 degrees or 360. But these arms can move up to 570 degrees. So it gives me great degree of articulation than human. And this is how my operating theater, looks like. So this is called the robotic surgical theater. This is me, the surgeon sitting here. That is my assistant. That is the patient lying down. These are the robotic arms. That is your nurse. That is another nurse. This is helping to teach. So this is how a typical robotic theater looks like. Are we getting this, Zamin?
Yeah, getting absolutely. This really helps picture the situation. It's, I couldn't have imagined that the doctor is almost away and even facing away from the patient while this is
Okay.
happening.
So you understand why it is different, right? But why is this more better and safer? Because it gives you precision, okay? Just move on. So this is how it looks like. There's somebody lying down and you have these little holes in the body. That is all you have. So you don't have any big cuts. You have 4 cuts. Each cut is about 8 millimeters in size. Okay, it's about 8 millimeters to 1 centimeter or less than a centimeter. So you only have 4 small cuts, so patient can have less pain and go home faster. So this is how a theater looks like. That is the surgeon sitting looking into the console. You're right. He does not look at the patient. And these are my table assistants who are working with, who are just helping, standing there, helping me to set up the case. So this is a typical day in our life. Okay, all of you, if you don't like to see gore, close your eyes. Okay, but this is how inside looks like. This is 3D vision, okay? And these are my mechanical arms. So basically, these are my arms extended into the human body. This is my right hand. This is my left hand. I can operate to less than a millimeter precision. As you can see, there is hardly any blood loss. So that is why robotic surgery is safe, okay? And not only safe, it's more precise. That is what you can see. It works like Microsoft. You see what you get, right? So this is exactly what you see. Because thoracic surgery is a complex surgical operating area, you have very big blood vessels and all that. Safety is very important. And the robot helps me to be a more safer surgeon. Okay. Uh, let me, okay, I'll just add one more slide just to make sure that you get this. So what are the big advantages, which is obviously going to be your next question. So I'll put these lines for you, okay? So we have all the cuts are about 8 millimeters to 1 centimeter, as I said, okay? So you have less pain after operation. Nobody cuts open your chest. 2, you have less blood loss, okay? On an average, for a thoracic operation with the robot, you use somewhere between 30 to 50 mils of blood. If you do it in the open way, the average loss is equal to about 200 to 250 mils. So you can understand whether you want to lose more blood or not, you can decide. Shorter hospital stay. Yes, people stay for an average of 2 to 3 days after robotic surgery in the hospital. And the conversion rate to open surgery, meaning you make it an open operation, becomes much less if you use the robot rather than using video-assisted surgery. And then lastly, most importantly, you have very less complication rates. Let me stop my share. I'll get back to Zerman. Yes, all yours.
That definitely gave all of us, I think, a great picture of what that really means, and perhaps a more realistic picture than what we had in mind. So, Dr. Aneez, is this a growing adoption of robotic surgery, particularly in your field, or do you find it equally as adopted in other disciplines of medicine, or where would you say the lead is in adoption of robotic surgery?
Very, very, very good question. So when the robot was invented for surgical discipline, cardiothoracic surgery was the lead field. So it was designed for cardiothoracic surgery because the technicality and the nicheness which was required, the robot was a great help. But the initial adoption rate from the fraternity of cardiothoracic surgeons was slow. So who took up the majority of the bulk is the urologists. So nowadays, I think urologists spend more time with the robot than they spend with their wives or family, okay? So the urologists are with the robot all the time. So they are the major adopters of robotic surgery. The second will be people from the general surgical field, which is the colon, yeah, colorectal surgery, and people who do other kinds of general surgery in the abdomen, including things like hernia, upper gastric cancer, and all stuff like that. But having said that, thoracic surgery is the fastest growing field in robotic adoption for the last 5 years. They're going leaps and bounds. almost every field, including gynecology, including orthopedics, in all fields have adopted robotic surgery with great outcomes.
Okay, that makes sense. The outcomes that you actually outlined in your presentation. So it's very easy to see that there definitely are a lot of benefits associated with it. But you would understand that as a physician. As a patient, do you find hesitancy or lack of comfort, when you provide the option that this could be a robotic surgery and there may be better outcomes, or less recovery time? Do you find hesitancy in a patient to feel comfortable with that idea compared to the traditional, physician, human kind of aspect of it?
Very good. You see, nowadays, like how we are talking to each other today, we wouldn't have thought about this without the pandemic. Okay? That is point number one. We are already right now innovating. And I think so are my patients. Actually, my patients come to me knowing what I do. They exactly tell me what they want, and they know all about the complications and how it's done and stuff. So people read about it all the time. So to answer your question, about 10 years ago, when the adoption rate was being picked up, there was a little bit of intelligence, I would say, lack of spread of message. That is the key word. But now everybody is well informed, and people come asking for robotic surgery because they know it is the best platform to get operated on. And they actually feel very comfortable with it.
Oh, that's very interesting to know. And you mentioned the pandemic, and I wanted to wait a little bit later, but I think this is a good point to ask you. As a physician and as a specialist in this field, have you seen a change in maybe the attitude of the patients, but also kind of in your discipline in relation to the pandemic and modes of treatment?
We get the raw deal in the pandemic because we operate on the lungs. Yeah. So it is all about us in this field. So when we operate, all our colleagues are at risk, including the anesthetists to nurses to everybody in the field, because we are directly exposed to an organ, which supposedly is the reservoir for the virus. But having said that, we take all precautions. Patients need to test negative for the virus before we operate, blah, blah, and all that. But you will always have somebody who is asymptomatic and who just not been diagnosed will slip through the net. It is quite possible. I think that is where robotic surgery helps, because this is a completely enclosed system of surgery. So there is no air leaking out anywhere. Nobody is breathing anything coming out of the patient. Everything is in a closed system. And even the gas which we evacuate out of the patient goes through a virus filter and then is being evacuated out into into the system. So in that terms of virus spread and virus prevention, I think the robotic surgical field is quite way ahead in terms of that. As far as the pandemic goes, unfortunately, cancer is cancer. Okay, and if you're an early stage lung cancer, nobody is going to wait. They want it done and removed like yesterday. So time is very crucial and essential in lung cancer. We slowed down initially when there was a complete lockdown, but now we are back at full operating speed, and I would say we are working at 98% capacity now.
Oh, wow. And Dr. Aneez, in your opinion, speaking as a specialist that you are, what are the challenges and obstacles that you've seen in robotic assisted surgery and the adoption of it?
The biggest bugbear in the room is cost.
Okay.
Yeah. Having said that, now in the last 1 year and in the next 2 years, you have multiple robotic companies coming up with their own robots. So it's very simple. Once you democratize any society, it becomes much cheaper and simpler. Having said that, the robot I work with the company is called Intuitive, and they are leaders in this field, and they are way ahead in this game. The average cost of robotic surgery today if you calculate in terms, is probably not that much, because with robotic surgery, you save on the number of days the patient stays in the hospital. You save on the amount of pain. You save when the patient gets back into the society as a normal human being. You save when the patient can go back and have his lung cancer treatment from the medical oncologist. All these is money saved. And if you calculate strictly in terms of health economics, robotic surgery is actually not expensive. It kind of evens out at the end of the day.
That's so interesting. And I would actually also love to hear your comment and thoughts on, as you're familiar with Singapore and the region surrounding, and then the UAE, Dubai, Abu Dhabi, and the region surrounding. What's your opinion on the adoption of this technology over here based on your experience?
I do visit UAE. Okay, we have friends there, but I've never worked. I worked with friends who are in the video-assisted surgical field, but they do have a robot there as well. The adoption is quite picking up fast in Dubai and Abu Dhabi region. As far as Singapore goes, Singapore was one of the earliest adopters of robotic surgery. So it's not a fair comparison. But if you compare the region, which is around us, Malaysia, Thailand, Vietnam, they are picking up. They are buying robots left, right, and center. Every hospital wants a robot. People started off thinking it's a fancy instrument. Then they realized, no, this really works for us, works for my patient. So now the adoption rate is much different. And the cost has come down considerably. So people are starting to adopt more. And I'm sure in a country like Dubai, there is financial muscle enough, and also the technological know-how to carry off robotic surgical procedure easily in all fields. Adoption will be very smooth, I think. And I personally know many colleagues who operate with the robot in the UAE. They're all very good people, and many patients have started to like the outcomes with the robot, even in the region.
That's greatly promising. And I think we can also see the growth and information that's coming out, as consumers to really understand the options that we have. Would you be able to shed some light on what other types of surgeries can be conducted robot-assisted surgery?
Okay, so in the chest, apart from the heart, you have a lot of things. Okay, so we have spoken about the lung so far. Okay, the other most important organ which is concerned with cancer is called the esophagus. So esophageal cancer is also a relatively common disease in that part of the world, especially in the belt of northern part of Pakistan, India, Bangladesh, and up towards the Emirates, that side, you do get a lot of esophageal cancer. Tackling such a complex cancer with the robot makes life easier for everybody. Okay, I'm going to share screen with you again. Just give me a second. Okay, so I'll be quick. I'll just run through in 1 minute. So if you look at this, is the same thing. This is called the esophagus. This is where you swallow your food, okay? And that's, you see a tumor bulging there. So this is called esophageal surgery. This is basically for esophageal cancer. You will find that you can operate with this, and it's the same modality. Before, you used to cut open your whole chest and your abdomen, but today you will have 4 small cuts in the abdomen and 4 small cuts in the chest, and you can practically go back to your general ward after a big operation like this. Okay? There are some difficult tumors in the chest as well. Apart from the esophagus, you can have big nervous tumors. Okay, this is called a neurogenic tumor, meaning a tumor which is made up of nerves. This is sitting exactly across the biggest blood vessel of your body. That's called the aorta. And you can see this huge tumor there. Normally, people will go make a big cut to take this out. But with the robot, you can see the precision, the safety, hardly any blood loss. And then these patients go home actually the very next day after an operation like this. So life is much less complicated with minimally invasive surgery methods like this. Okay. Last but not least, the most important problems is there's another organ in the body which we forget, which is called the thymus. It usually disappears at the age of 12, but in many people it is still there. Usually requires opening up your chest and your breastbone, but with robotic surgery you can do 3 small cuts and you can take such a big tumor out. Even if it is involving the heart, you can see here the heart's beating. Even if it is involving the covering of the heart, we can still operate with the robot and get the tumor out quite safely. So you can do a lot of things. That's your heart beating. I'm just putting the heart cover back. Okay. Yeah, there you go. I'll just put this slide for you as general public, for you people to know that although I may speak like I'm the only hero involved in management of lung cancer, I am not. Any good team should have these 4 people, and they are all my team and colleagues. So it's our common goal to fight against the cancer. Okay? Cancer is the common enemy. And to defeat it, I don't mind taking many people to war with me. And all these people are involved in the battle with me, my oncologist, my pulmonologist, and my pathologist. So although I may feel that, just give me 1 second. Yeah. Although I may feel like I am James Bond doing it, actually I am not, okay? I'm one of the characters in a play like this, okay? Where all of them have to, make it a good show, and then only the outcomes are good, okay? All right, I stopped share. Zalmin, yours.
That's such a wonderful explanation and picturization. So thank you so much for that. I'd love to know at this point, what do you see as the future of robotic assisted surgery? Where are we going? What are the possibilities? Love to know your thoughts on that.
It is hard to digest, but I can tell you that the way we are going, someday I will be replacing myself with a robot. There will
Really?
come a day, probably you will have a very sophisticated iPhone, maybe a version 25 or something like that. Okay, if you can spend $1,500 every year, you probably have an app button in your palm, and then they will guide you to an operating theater where you go lie down, and then make sure you have your credit card. You pay first, and then you lie down on the operating table, program your operation, and the nurse will guide you, and the operation will be done by the robots. That is the future. Why I'm telling you this? Because this is not some sci-fi fantasy. This is already happening in a small scale, for smaller surgeries, where autonomous surgery is coming in, or surgery with artificial intelligence, we call it. In the future, I think robotic surgery, and surgeons who deal with robotic surgery will be really at the cutting edge of curing disease.
Wonderful. Thank you for that. I think that's a little bit difficult for us to imagine, but it's great to keep that picture in mind. I would love to open the floor to some questions we're receiving. So if you don't mind, Dr. Aneez, I will read out some questions of our viewers. Great.
Please go ahead.
We have one, and I think this person is interested about the screening and early detection. So they're asking, at what age should both smokers and non-smokers start looking to get checkups for this kind of cancer, for this type of cancer?
I think if you're looking for screening, my friend, if you're a smoker, first stop smoking, okay? You've done yourself a big favor there, okay? And then if you want to screen, I think there are different groups. We suggest to start screening after the age of 45, okay? If your first screen is negative, then you can wait for 2 to 3 years before you commit to the second screen, and so on and so on. But I think at the age of 45 is a reasonable one at this present day world.
Mm-hmm. Great. We have a next question. In terms of recovery and inpatient stay in hospital, does robotic surgery offer any difference as compared to other surgery, such as traditional open surgery?
Definitely. Okay, so if you go for traditional open surgery, which is called a thoracotomy, for lung cancer, your average stay is about 5 to 7 days.
Mm-hmm.
If you have good outcomes, that means you're already having very good outcomes. Whereas in comparison, the average length of stay for robotic lung cancer is between 2 to 3 days. So you know you've already cut that down by half.
Almost half. Wow.
Most important than that is the functionality. Like when do you get back to real normal life and how you can lift your hand and go to market and carry your bags and stuff like that. We find that with robotics, you can get back to normal life in 2 weeks. You can be doing your own things in your normal life. With thoracotomy, it takes about 4 to 6 weeks for people to get back to full functionality and recovery. So open surgery is whenever we can, let's put it this way, we avoid open surgery. The other important comparator is with video-assisted surgery. Video-assisted surgery is also done with keyholes. Yeah. So you're arguing is that that is also with keyhole. So what is the big difference? The big difference is in the technicalities. Very hard to master video-assisted surgery when compared to robotic surgery. That you need to understand. And it is not the same. The more complex the disease, the more the chance that the video-assisted surgeon will have to convert it into open surgery. So you're back to square one. But with the robot, the chance of conversion is less. So you stay again as a minimally invasive procedure. So remember that. So these are the big advantages and differences between open, robotic, and VATS.
Great, thank you. We can definitely see those advantages. We have another question, and I think I expected as much to have quite a few questions about smoking. So here we have, how young do smokers contract cancer? So I think they mean in age. What is, if you've been smoking since you're 18, let's say, when should you be concerned about this?
Okay, first of all, the earlier you start, the higher the risk. That you need to understand, okay? So the earlier you start, the higher your risk. The youngest smoking-related cancer I have seen is at age 24.
Wow, very young.
That's not good, yeah?
Mm.
That guy started smoking when he was 14, so you kind of know. So message, let me reinforce, if you're a smoker, throw that away, quit right now. Even for your lung function and heart function to come back to normal, it takes 2 years after you quit smoking. The chance of your developing lung cancer, as everybody else in the population, will be drastically reducing year on year the day you quit smoking. Okay? And the changes in your body actually happen 8 hours from the time you stop. So please go ahead and quit. There are much better ways to spend your money.
Dr. Aneez, I just want to ask a question of my own that I feel, I hear this debate a lot, let's say, that, there's smokers who, smoke every day or, multiple times a day. And then there's more recreational smokers who perhaps defend that, I only do it once or twice a week and it's intermittent and it's not, a daily feature. Does that have an impact, or is it less risky on the lungs? What's the difference there?
There are hardly what you would call social smokers who smoke once or twice a week. Yeah, that population is probably very, very less. Okay, and I think that's where you start, and that's how you start, and you progress on to become a regular smoker. Okay, the problem with smoking is that it is an addictive feature. Okay, the offensive things come not only from the nicotine, which causes the addiction, but from also the carcinogens, which are from burning a cigarette. So now don't come to me talking about e-cigarettes or vaping. They are worse than natural cigarettes. That is not a substitute, okay? It's a bad substitute to have. It'll only worsen your addiction, and it has a lot of other lung problems apart from lung cancer. You should understand that. So if you are a casual smoker, and if you're strictly doing one cigarette once a week, then I wouldn't even consider that serious, because I know that you're going to stop after 3 to 4 weeks. But there's no such thing as a casual smoker. You're either a smoker or you're a non-smoker. Remember that.
Great, thank you. So we have a next question. Is it true that lung cancer is more a genetic cause than smoking related? though smoking is something that triggers it. I think this is that, analogy of the lifestyle pulling their gun trigger. So I think that's the background analysis of the question.
Okay, there are two ways to answer this question. Okay, yes, smokers always will be in denial saying that smoking didn't cause cancer. But that I understand the analogy coming from a smoker. But from a technical point of view, yes, there is a genetic relation. But that genetic relation is more and more in parts of Asia, and it's more and more in women. That is what we have correlation. There are something called mutant receptors. They are called EGFR. There are many targeted cell therapies which are targeted at specific mutations. They are called EGFR, ALK, ROS, and so on and so forth. These kind of mutations, we are able to diagnose now. We don't know whether it was there before, but we find in the average Asian population, 65% of them are positive to these mutants, especially women who are non-smokers. So there is a genetic relation, but there is no defined genetic relation to familial transmission of lung cancer. Remember that. My mom got it, I'm getting it. No, there is no definite proof of it. You definitely are at a higher risk if your familial people are affected by cancer, yes. But definitely this is not a transmissible cancer which is familial linked. There is no proof yet. Genetic mutation, yes. Why it is happening? Probably environment, gas related, pollution related, yes. Just because I quit smoking, it won't come? No. Should I stop smoking to prevent cancer? Yes. Will completely quitting smoking help me prevent lung cancer? I can't say yes, because we call it, the word is called causal relationship, CAUSAL. Please Google that term. Causal relationship is the word between smoking and its relation to lung cancer.
Thank you. Thank you so much for that. I'll just take a moment to share a lovely message that a physician in Qatar has shared for you, Dr. Aneez. That was an excellent, informative, and comprehensive presentation. I think physician to physician compliment. So thank you, Dr. Habib, for watching us. And thank you again, Dr. Aneez, for the presentation. Before we move on to our next question, I just wanted to share that with you.
Thank you very much on my behalf. Appreciate it.
So we have another question. One of our viewers is asking, when a patient is diagnosed with lung cancer, should one consult medical oncologist or see a lung surgeon first? Which treatment, surgical or chemo, offer a higher success rate?
Zarmin, can you come again with the question? I lost you at the beginning.
I'll repeat that. When a patient is diagnosed with lung cancer, should one consult a medical oncologist or see a lung surgeon first? Which treatment, surgical or chemo, offer a higher success rate?
Okay, let me take a step back and start from the beginning. Okay, so usually lung cancers are diagnosed by pulmonologists, meaning respiratory physicians. Okay, they don't deal with the cancer part themselves, they diagnose the cancer. And then they will stage your cancer into stage 1 to 4. Okay, stage 1 being good, stage 4 being bad. All stages, okay, then we should divide the treatment into these three things. So lung cancer can be treated by 1, surgery for lung cancer, 2, oncology, medical oncology, 3, radiation oncology, radiation medicine, and 4, alternative. You should understand that medical oncology and radiation oncology give control over lung cancer. The key word is control. But whereas surgery gives you a chance at cure from lung cancer, the key word being cure. So for stages 1 to 2, the first option is to go for surgery. Okay? If needed, then the medical oncologist will follow you up with adjuvant treatment, we call it. But the first step is surgery. For stage 4, the first step is medical oncology. They will treat you directly because the surgeon doesn't get involved or rarely gets involved in stage 4 lung cancer. Stage 3 is called what we call the gray area. This is called the area of personalized or tailored medicine nowadays, where a group of surgeons, medical oncologists, and the respiratory physician, my picture about teamwork, which you saw, this is where we get involved, especially in stage 3. We will all sit down to make a combined decision whether this guy goes for medical oncology first and then goes for surgery, or he goes for surgery if possible, then goes for further treatment later. So it's a combined decision which is done by a tumor board. I hope that clears up your answer.
Thank you. No, that's very straightforward. We have another question, and we received something similar on our last webinar, which was also on breast cancer. And this question is: are cancer patients at an increased risk for COVID-19 infection? Have you seen any kind of correlation, or is it more fear?
Okay. We are blessed that we don't have a lot of COVID cases in Singapore. So our relations to cancer patients having COVID is, the knowledge is limited. But in the worldwide data and knowledge, you can go by this premise. If a patient who's getting cancer treatment usually will have his immune system down. And when your immune system is down, that's when the virus attacks you. So basically, you are at a high risk of getting a viral infection when you are on chemotherapy. So, or when you're having a cancer which is uncontrolled. So if your immune system is down, then the virus becomes active. So you definitely are at higher risk, and please take precautions if you are on it.
Thank you for that. Definitely, we should all be taking as much precaution, particularly if you're at risk. We have a question from a general physician in the UK. Does lung cancer prognosis depend on histology?
Wow, that's a complex question. Okay, but we can answer it. When I started to medical school, there are basically two kinds of cancer. One is called a non-small cell lung cancer. Another one is called a small cell lung cancer. Let us put it this way. Small cell lung cancer forms about 15% of all cancers, and non-small cell forms about the remaining 85%. Small cells is usually treated by chemotherapy and medical oncologists. Non-small cell lung cancer is usually treated by other modalities, including surgery. In the non-small cell, you have further divisions, but I'll talk to you about basically two divisions. One is the squamous cell, and the second one is called the adenocarcinoma. So going back to my statement, when I started med school, the most common lung cancer was a squamous cell carcinoma, nearly 85%, and everything was smoking related. So people who smoked got lung cancer, it was a squamous cell, and they said, yeah, that's it, you got it. So now the tables are turned. So now we find that close to 65 to 70%, at least in the Asian population, is adenocarcinoma. And the remaining 30% is squamous cell. So the squamous cell's relation to smoking remains, but why is the adenocarcinoma increasing? Many reasons. One, genetic mutation, environmental pollution, associated factors, lifestyle factors, we don't know. But we definitely know, but I can give you a lot of reasons. But we feel that environmental factors are much involved in the growth of adenocarcinoma. Especially, they're more common in women. They have a big relation to non-smokers as well.
Great, thank you. I think that was a great question from Dr. Basha in the UK. Thank you for the question, and thank you, Dr. Aneez, for the answer. I think we will take one last question. I've actually received two questions that are quite similar, so I will summarize it in one. Dr. Aneez, do you find that robotic assisted surgery can affect the personalization of medicine? So I think that the question is really that, today doctors are really building a relationship with their client and understanding that, is this a threat to it? How can we place this and accept it?
Okay. Do not take robotic field as a foe, it's your friend. There was a study done by PricewaterhouseCoopers where they looked at many patients around the world, and given a chance, they were asked a question. Would you like to relate with the doctor? Would you like to speak to a robot for your consultation? Different countries had different percentage of answers, okay? In the UK, for example, the answer was 55% of the patients wanted to speak to a doctor. 45% didn't want to speak to a doctor. They were happy going to the robot.
Oh,
In Nigeria, 75% wanted to speak to the robot. 15% only wanted to speak to the doctor. What does that tell you? Basically, it is related to the quality of healthcare available in that country. The doctors are not easily available in remote parts of Africa. So they are very willing to sit across the screen and talk to a robot who will give you answers. Robots they are your servants, but they are mechanical. And I think in the future, they will think a lot better and faster. So let us embrace this technology. I think we should be able to relate that you don't need a lot of people helping you around at the counter to talk to you. You don't need, a special attendant there. So nowadays we go to the counter. I show my ID card. I get automatically an appointment. I get screened in. I can go there. I see the attendant, and then I see the doctor. I can see all that going away slowly because you will get your appointment at home. Probably later you won't see the attendant. He or she won't be there. Then you go directly see the doctor. Someday the doctor is going to disappear too. So robots are here right now. They are helping you. In the future, they may replace you, but we are not at this point in time. So try and embrace robotic surgery and robots in medical care. They are your future.
thank you so much, Dr. Aneez, for answering all the questions we got. If there are any more questions, please feel free to email them in and we'll make sure Dr. Aneez has a prepared response for you. But right now, Dr. Aneez, I'd love to ask you for a closing message for our viewers today.
Okay, let me just put this on before I close.
Sure.
Okay. If you're a smoker, quit smoking. Let's start there. Okay, that helps. This is Lung Cancer Awareness Month. Okay, so I have to fly the flag to say stop smoking. Okay, it improves your lung health, it improves your heart health, it improves everything. Okay, you will look much prettier, you will look more handsome, whatever, because it affects your skin too. So it is important to quit smoking. Second, if you're of a certain age and if you are in a high risk category, make sure that you go for screening. It is very important. Okay, remember, if you get this lung cancer early, you can get cured of lung cancer for stage 1. Your cure rate is close to 85%. So you have an 85% chance of curing yourself of lung cancer. Remember that. So that is why screening becomes important. So get your screening done. Make sure you have some kind of screening package. Follow what is instructions being given to you. 3, maintain good lifestyles. That is all I have to say. Okay, just maintain healthy lifestyles. Have some form of exercise. Okay, all right. Whatever exercise suits you, please do it. But you should have some form of physical exercise because it helps to keep your immune system up. And your immune system is your biggest friend in the fight against cancer. You should understand that if we don't have an immune system which is good, by now all of you will be cancerous. Your cancer cells are kept at bay by your own body's immune system. That you need to understand.
Thank you so much, Dr. Aneez. That was a lovely closing message. I'm certain our viewers had a lot of benefit and insight to this session. I would like to thank you for being with us here today. And I would also like to thank everyone who submitted their questions for Dr. Aneez on this session about smart advice for lung cancer and lung cancer awareness and robotic thoracic surgery. This was most helpful, and we hope you can join us at our next Wellness Wednesday webinar. Thank you, everyone.
Thank you, Germaine. You have a good day.